while pharmacotherapeutics will go for, because in that diagnostic tools are more comparatively. So basically the drugs which are used in bronchial asthma and COPD. I have asked you to go through the anatomy physiology, where at the end of that topic in Totora all these diseases are given. What is asthma, what is COPD, so everything is given in that book. And apart from that, in pathophysiology also these things are there. So there you can have more details about it, but whatsoever details still possible which are more important, and that will narrate through this. So what are these diseases which are there, which are related to respiratory system? Example of these are the bronchial asthma, cough, allergic rhinitis. Chronic obstructive pulmonary diseases is also called as emphysema. Actually, bronchial asthma is also called as a COPD because it is a chronic. It causes obstruction of bronchi, and therefore we call it as a COPD. So what are these? Example, asthma is also chronic inflammatory disorder of bronchial airways. It causes obstruction of the airways, and because of this there is a decrease in the airflow through this. It can be because of any external stimuli like pollen grain, cold air, or tobacco smoke, or many other allergens are there. Any other allergy make it. Then what are the characteristics of airways in asthmatic patient? There is a hyperactivity of airway. So there is a abnormal sensitivity of the airways for various external stimuli. Means example, many can have dust. So dust is everywhere. Everyone is not getting any problem, but these people may get problem because that airway has got hyperreactivity. Many people have got in dust, example chalk dust. So those teachers who are using chalk, they can have problem. Then other thing is there is always inflammation, that is swelling of this bronchi, and thick mucus production. You can imagine already pipe size was big. Now there is a swelling, so the lumen of pipe has reduced, and in that the thick mucus is produced, which is sticking to it. So still it is causing more. And lastly, because of all these things, there is a bronchospasm, that is constriction of the bronchial muscle. So these all three important characteristics are there, which are seen in asthmatic patients. We can see here that these are the bronchi, trachea, then bronchi and bronchioles. So in this bronchial, if we take the section, we will find that this much is airway, this much is a lumen inside it is present, while because of the thickening and because of the mucus which is there, see it has reduced too much. And see, this is normal airway, and during asthma, so you can see this is comparatively thinner. Then here you can see that comparatively it has become thicker because of the this inflammation which is there, and simultaneously there is a constriction. So this has also reduced, the lumen is also reduced, and to add into it, the third important is increase in the thick mucus. So because of all this, one is the section shows that it was a clear one. Normally here it is in three things simultaneously: bronchoconstriction, inflammation because of that lumen, and third thing is the presence of mucus. So because of these three things, the airway passage is restricted, and the patients can suffer from hypoxia because less oxygen or less input of air will be there. So what are the symptoms of the asthma? It shows the recurrent episodic attacks of acute bronchoconstriction, shortness of breath, chest tightness, wheezing, rapid respiration, and cough. Acute bronchoconstriction we have seen above. Because of that shortness of breath, means difficulty in breathing, we can say. Chest tightness, the feeling of tightness in chest. Wheezing because of the thick mucus and all, a very typical type of whistling like sound that comes during respiration. Since there is a hypoxia, the respiratory center tries to match it up, tries to copy, but and there is a rapid respiration, and because of the obstruction, the cough reflexes are activated, and therefore the person is coughing many a times. These symptoms can happen each time the airway they are irritated by inhaled irritants or allergens, and therefore this asthma will be there. What are the causes? It can be because of certain infections, it can be because of the emotional conditions which triggers this inflammatory situation. This can be stress, exercise, pet, because dander is present, the dandruff or the small hairs which are there from the pets. This can seasonal changes, and some drugs like aspirin, beta blockers can cause it. Okay. Then what are the innervations which are there? What kind of neurons are supplying to this portion? So these are receptors are there, like irritant receptors which are present in upper airways. Then the C fiber receptor are present in the lower airways, and these are stimulated by exogenous chemicals, physical stimuli like cold air, and exogenous inflammatory mediators are there. These are causing the stimulation of these receptors, and from that the respiratory center will have the actions through the efferent nerves. Example of these are parasympathetic supply is there on the M3 receptors in smooth muscles and glands. So this will cause contraction of smooth muscles and increase in the secretion from the glands. There is no direct sympathetic supply, but yes, beta 2 receptors are present in the smooth muscles just like they are present in blood vessels and glands. So same way it will be there, it causes vasodilation. Similarly, this beta 2 stimulation will cause bronchodilation or relaxation of the smooth muscles. So this is how innervations are there. From CNS various nerves are coming. So these are afferent are there which are from larynges, and these C fibers are there from the lower portion. This green color are there which are going to CNS. So laryngeal, then C fiber and A fiber which are there, they are going. C fiber is from the upper one, and this A fiber they are reaching to CNS, and in response to that and as such control, there is a vagus nerve which is a parasympathetic nerve, and because of that it causes bronchoconstriction and increase in the glandular secretion. So this is what the action is. What are various anti-asthmatic drugs? Example of these are bronchodilators, which are acute relief medications. They will relieve the acute episodic attacks of the asthma. Then they should reduce the frequency of attacks and nocturnal awakening. For that we are using drugs like anti-inflammatory drugs which are used for a prophylaxis and therapeutic. These are basically two uses of drug. Any drug, whenever it is used, prophylactic is to prevent, and the therapeutic, that is, these are the drugs to cure. Already symptoms are there, it is known problem is there. So in that case, to cure whatsoever drugs are used, we call them as a therapeutic use, and to prevent any kind of problem, that is at present there is no problem, but in future or there are chances of a problem, then we call it as a prophylaxis. So the drugs are used in two ways, therapeutic uses and prophylactic uses. So here we are using anti-inflammatory drugs. They are used as a prophylactic or for the controlling or to have the control over the this bronchial inflammation. So what are other drugs? We have got various drugs, as we have seen. We broadly classify them into few things. One of the classes we call them as a bronchodilators. They are causing quick relief because the problem is bronchoconstriction, and because of constriction there is a increase in the airway resistance. So to reduce this airway resistance, we have the drugs. These drugs are there which will cause the treatment of acute episodes of the asthma. Example of these are beta agonist, beta 2 agonist we are using. Then the drugs which are acting on the muscarinic receptors, blocking the muscarinic receptor. Just now we have seen M3 receptor, when it is stimulated it causes bronchoconstriction, so and it is always present. So anti-muscarinic will cause the decrease in the bronchoconstriction. The next is the xanthine preparation. These are, we shall see them again, they are actually improving the beta 2 activity. Then anti-inflammatory agents are there. There are many type of anti-inflammatory agents, because inflammation is one of the important major contributor in this. So these are example of these drugs are corticosteroids, mast cell stabilizers, leukotriene antagonists, anti-IgE monoclonal antibodies, and long-acting beta-2 agonists. These are anti-inflammatory agents which are there for that. Now what happens in asthma is, we have seen three major things, or in pathology you will study it. People say that this asthma is a mix of everything. It can be genetic, because some people are more prone for asthma, others are not, so they are hypersensitive. So this is genetic reason. Second thing is, people say that there is a the disease is immune related. So yes, it is immune related, because the bronchi are, the hypersensitive bronchi are there, they are acting on the small foreign object, maybe dust or dander or whatsoever it may be. So because of that, they initiate all immune mechanism where histamine is released, Ig antibodies are released. So these all immune reactions are there. Then third component in the asthma is inflammation. So when there is a action about this, when there is these agents are acting, inflammation, these immunological agents are acting, example histamine, etc., they are bringing out inflammation. So there are many inflammatory mediators which are there, and these inflammatory mediators are contributing into asthma. So as we have seen, there are many things which are there, but end effect or end impact they are causing is what? That they causes the constriction of bronchi, they causes inflammation of bronchi, they causes increase in the thick mucous secretion, and because of these three important things, there is a decrease in the passage of air. We call it as an increase in the airway resistance, and because of that, normally whatsoever amount of air we can take during normal one breathing, that much air will not be there, and if it is not there, then body will face hypoxia. Because of that, all the reflex mechanism will be working. For that, there will be reflex coughing will be there, reflex increase in the breathing rate will be there. So all these effects will be there, and these all effects will be useful, will be contributing into asthma, and we have to consider these effects for the treatment one after another. So let us have various drugs into it. Example of this is anti-asthmatic drug like bronchodilator. So these are quick relief medication. Why? Because these are having ability to cause the dilatation of the bronchi. If the bronchi are dilated, then the airway resistance will be reduced and more air flow can be there. So they are used to relieve the acute attack of bronchoconstriction. Example of these are beta-2 adrenergic receptor agonists, antimuscarinics, and xanthine preparations are three important agents in this category. First of this is beta adrenergic receptor agonist. The mechanism of action, we have seen it during ANS, that beta adrenergic receptors are having action through direct beta-2 stimulation. It causes stimulation of adenylate cyclase. Because of that, it causes increase in the cyclic AMP, and because of that, there is a bronchodilation. Okay, so this is the mechanism which we have seen during beta-2 mediated effects, or how the beta-2 receptor is there whenever we have seen ANS. These drugs will inhibit the mediator release from the mast cells, is additional activity, and they will increase the mucus clearance by increasing the ciliary activity. You must be knowing about the cilia are present in the bronchial muscles, rather lumen of the bronchi, and whenever any particulate matter is there, this cilia will try to propel it upside, and because of that, this propelling will help in clearance of the mucus. So these are three important mechanisms these agents are causing, that is, these are doing direct beta-2 stimulation, and this causes stimulation of adenylate cyclase, it increases cyclic AMP, and therefore it causes bronchodilation. And they are very powerful bronchodilators, and these are the only therapy whenever there is a severe bronchoconstriction. Okay. Then next is this, we have got various classes of that. The naturally occurring is epinephrine, and other one which is non-selective is isoprenaline. We have seen all these agents when we have seen ANS. Epinephrine is normally selected from the adrenal medulla and also various sympathetic neurons. Then others are there which are selectively beta 2 agonist, and they are more preferable. Why they are preferable? Because isoprenaline can cause cardiac action. It will also act on beta 1. We have seen the difference in the effect of epinephrine, norepinephrine and isoprenaline, if you remember, on cardiovascular system when we have seen ANS. So we have seen that isoprenaline will cause beta 1, beta 2 actions and no alpha action, while norepinephrine will call alpha actions also. So since they are not selective on alpha and beta, again beta 1, beta 2, so they are acting on all types of receptor, alpha also, beta also, and beta 1, beta 2 also. So because of that, all these adverse effects they will able to show. But epinephrine is that way very faster. If there is a emergency, then epinephrine is comparatively faster in action, and it is a drug of choice during emergencies. Then another class of drug are the selective beta 2 agonist. Example of these are many: salbutamol, then albuterol, terbutaline, salmeterol, formoterol. These are many drugs in this category which are having similar names, and these all drugs are used in various ways. It can be parenteral, it can be by inhalation route, it can be by oral route. Anyway, these are used, and they are most widely and most important drug of choice in bronchial asthma. So first one, epinephrine, as I told you, it is a potent bronchodilator. It has got rapid action. Within 15 minutes it will be able to show. So when there is an emergency, when there is a serious case, then epinephrine is preferred in hospitals. It can be given by subcutaneous or by inhalation route, that is by aerosol or nebulizers. It has a very short duration of action, around 60 to 90 minutes, and therefore it is a drug of choice for acute anaphylactic shock. There are many drugs which are causing, or many chemicals which can cause this anaphylaxis, which is because IgE mediated hypersensitivity reaction, and this IgE mediated hypersensitivity reaction is very dangerous. If you remember during our class regarding toxicity, we have seen it that penicillin like drugs, they are comparatively very safe. They have got very good therapeutic index, but where it is causing hypersensitivity, in that patient it can cause death immediately. So these are the problem, and this is called as anaphylactic shock. So these are dangerous one, and therefore epinephrine is important drug. It is a drug of choice in that condition. But as we have seen earlier, it is having, see, these are what we call as a, this is inhaler. Nowadays there are various types of inhalers are available. Some of these are called as a meter dose inhaler, so that when one's pump will be there, exactly that much dose will be going. So that is called as a meter dose. In other, they are not meter dose, they are called as a DPI, that is dry powder inhalers. So there are two types of inhalers are there: dry powder inhalers and this meter dose inhalers, and they are taken. Even the pharmacist should be able to guide it. And then another one is known as a nebulizer, that the water is there, through water air passes, and it will create steam, and along with steam the drug will go. So in vapors the drug is administered, and this is what nebulizer is. What are the disadvantages? I told you, it is not, it has to be given by parenteral or these routes. It can cause hyperglycemia, it can cause serious side effects, because we have seen it can act on alpha, beta 1 also. We need only beta 2 actions. It can cause tremors because of the skeletal muscle actions, and it is not suitable for asthmatic patient with hypertension or heart failure. So in that cases it should not be used. So because of this it causes hyperglycemia, so cannot be used in diabetic patient. It is contraindicated in diabetic patient. It is contraindicated in serious patient like hypertensive or heart failure patients. We cannot use it. So these are the things with the epinephrine. So we have to remember that epinephrine is only used, or it is only preferred in conditions where the drug is required in emergencies. So it is emergency medication. Then other agents in that class, in adrenergic class or adrenergic agonist class, example of this is called as a selective beta 2 agonist. So drug of choice, we have seen they are for acute bronchial asthma. They are mainly given by inhalation, as I told you, metered-dose inhaler, or that is called as MDIs or nebulizers, or one more I told you is DPI, that is dry powder inhalers. It can be given orally, it can be given parenterally. I told you about this. Short acting beta 2 agonist, normally they are called as a SABA. SABA is attending. So this is SABA. That is example of these are salbutamol, terbutaline. These are SABA, that is short acting beta 2 agonist, and others are LABA, that is long acting beta 2 agonist. So short acting are given in only acute situation where it is not clear. Long acting are given as a prophylactic where the asthma is there and it is occurring for long period of time. We shall see these details again when we shall be going through therapeutics. You just remember, mechanism is seen, mechanism is known. That is, what is mechanism? Beta 2. Beta 2 are acting through cyclic AMP, that is adenylate cyclase, increase in cyclic AMP, and because of that it is acting. So this is how mode of action, we have seen it in adrenergic system. Then short acting beta 2 agonist, example of these is, as I told you, abbreviation, people are using it as a SABA. SHO short is S, A beta is an agonist. So these are the SABAs. Salbutamol, it can be given by inhalation, it can be given orally, it can be given intravenously. Terbutaline is same. It has rapid onset of action, that is within 15 to 30 minutes. It has got short duration of action, and it is used for symptomatic treatment of acute episodic attack of acute. I told you these are, because short acting are useful for only acute attacks, because it is not good to administer drug again and again. So in short attack, in rapid attack, these drugs are preferred. The two benefits they are offering, that the onset of action is fast, means they will be immediately starting action within 15 minutes, but their duration of action will be 4 to 6 hours only. So that is expected that by that time you have got other medications or other things to do and you can do it. Then others are LABAs, that is long acting selective beta agonist. Example of these are salmeterol or formoterol. They act for around 12 hours. They have high lipid solubility. They create depot effect in the body. They are given by inhalation. They are not used to relieve acute episodes because they take time to do the job. They are used for nocturnal asthma, that is long acting relievers. They are combined with inhalation corticosteroids to control asthma, and they decrease the number of and severity of asthma attacks, because particularly those who are having chronic asthma, it can happen anytime, and particularly during night the more chances are there. So what are the advantages? They are having minimal CVS side effects, because they will not be acting on CVS. Beta 2 receptors are only present on blood vessels and not elsewhere. Suitable for asthmatic patient with hypertension or heart failure, because hypertension they will contribute into it. Disadvantages are they causes tremors of skeletal muscles, they can cause nervousness, particularly if they crosses blood-brain barrier. They develop tolerance because of the down regulation of beta receptors or beta 2 receptors, and they can cause tachycardia because of the beta 1 stimulation. So these are the adverse effects they are having. Then other drugs in that class are muscarinic antagonist. Example of this is epratromium bromide and tiotropium bromide. They act by blocking muscarinic receptors. They are given by aerosol inhalation. They are quaternary derivatives of atropine. They do not diffuse into blood. They do not enter CNS, and therefore they have minimal systemic side effects. They have got, but problem is the onset of action is delayed, it is late. The ipratropium is having short duration of action, that is only 3 to 5 hours, while tiotropium is having a longer duration action. But still, muscarinic antagonist is a second choice, or particularly when this beta 2 agonist cannot do the job properly, then muscarinic agonists are there. They are short acting bronchodilators, inhibit bronchoconstriction and mucous secretion. They are less effective than beta agonists, already I told you. They have no anti-inflammatory actions. They are main choice in chronic obstructive pulmonary disease, that is emphysema, and they are used in the acute severe asthma combined with beta 2 agonist and steroids when the asthma is very severe. That kind of, there are such kind of asthma attacks are there. They are called as a status asthmatics. So this status, whenever there status asthmatics, so this status asthmatics is very severe, which is not responding to the routine drugs which are given. So you have to increase dose and you have to increase number of drugs into this. So in that cases, these drugs are added along with beta 2 agonist. Then next are methylxanthines. Example are theophylline, aminophylline. Now for that again they are acting through beta 2 only, but only they are not acting on beta 2 receptor, but action is similar. That is, we know that when we stimulate beta 2 receptors, these beta 2 receptors will cause the activation through G protein, and through that it will cause activation of adenylate cyclase enzyme that will cause cyclic AMP. So this cyclic AMP will cause protein kinase activation, and thus there will be bronchodilation. Now this cyclic AMP is metabolized by phosphodiesterase enzyme, and this phosphodiesterase enzyme is inhibited by these agents. So if we inhibit phosphodiesterase, then it will not cause breakdown of cyclic AMP. So if the cyclic AMP is not broken down, then it will be acting for a long time, it will be acting for more time, and if it is acting for more time, then it will produce bronchodilation. So is one mechanism they are having. Then they can also act as a adenosine receptor antagonist, and they increase the diaphragmatic contraction, they stabilize of the mast cell. Some of these can do it. So these are various agents, they are acting on various places. This is the mechanism. We know that this beta agonist, they will cause formation or activation of adenylate cyclase, that will cause convert ATP to cyclic AMP. This cyclic AMP is broken down into 3-5- AMP, and this because of phosphodiesterase enzyme, theophylline will be blocking this. Okay, this cyclic AMP has got action of bronchodilation and on bronchial tree. This causes adenosine is there, so this adenosine secretion causes bronchoconstriction. So this is prevented because of this cyclic AMP mediated action. So what are the effects? It causes bronchial muscle relaxation, it increases the contraction of diaphragm, it improves the ventilation. On CVS it causes increase in heart rate, it causes increase in the force of contraction. In GIT it causes increase in the gastric acid secretion. In kidneys it causes increase in the renal blood flow and shows weak diuretic action. CNS stimulation, it shows a stimulant effect on the respiratory center, it decreases fatigue, elevate mood, and the overdose can cause same action like salbutamol etc., or beta tremors, nervousness, insomnia, convulsions. These all we have seen as, so the side effects are almost comparable with the beta 2 agonist and this, because a mechanism they are almost sharing. They are metabolized by cytochrome P450 enzymes in the liver. T half is around 8 hours. They have got many drug interaction because they are acting as enzyme inducers. So phenobarbital, rifampicin, these drugs will increase the metabolism of theophylline, which will cause decrease in the half-life of the theophylline. and there are certain enzyme inhibitors like erythromycin will decrease the metabolism of theophylline, and it will cause increase in the half-life of the drug. So it is a second line drug in the asthma, theophylline is. And for status asthmatic, I told you about status asthmatic. It is a severe condition where other drugs are not they are not giving any good response. These drugs are not showing good action, so, and the contraction is so severe that a patient can die at any time. So in that such very severe and very acute attack, this aminophylline is given as a slow infusion. Low therapeutic index, they have narrow safety margin. Monitoring of theophylline in blood level is very important, because many interactions are also there. If it increases, then it will cause serious effects, that is hypotension, arrhythmias. It will cause GIT effects like nausea, vomiting, and side effects like CNS side effects like tremor, nervousness, insomnia, convulsions. So these are severe side effects, particularly CNS1. Then other agents in this class, they are called as anti-inflammatory agents. Important of these is, so first class was bronchodilators. The next class is we call it as anti-inflammatory agents. We shall be studying these anti-inflammatory agents next time. Okay. These agents will reduce the inflammation. We shall see the mechanism of action of these various drugs, how they are acting, and for that you must understand few things. Although we have this inflammation or autocoids, yes, you people have studied autocoids also, isn't it? So please go through the mechanism of autocoids, what happens to prostaglandins, what happens to leukotrienes from arachidonic acid. Okay, what are the mechanisms of these agents, that is leukotrienes, what are the, particularly LTB4, that is leukotriene B4, what are the action? I will ask you on Monday about this. Then glucocorticoids, it is these are the agents. Corticosteroids, you have studied it in physiology. Okay, what are their mechanism of action, what actions they are showing. So I will ask you about glucocorticoid because you have studied it in physiology. Leukotrienes I will ask you because you have studied it in these autocoids. Then mast cells I will ask you because mast cell you know about from physiology of blood. So glucocorticoids you have studied in endocrine, leukotrienes you have studied in autocoids, mast cell you know about it in physiology. So these three I need to have. Then IgE I will tell you about, because IgE you might not have seen about it. So IgE I will tell you. You go through the physiology and I will ask about it, what physiology this is having. So we will understand how these glucocorticoids or leukotriene antagonist or such drugs are acting. So I hope this much is clear. If you have any difficulties, you can put it on our group, and you can take care and stay safe.